Rahman Rahim. We will talk today about the main clinical representation of the patients with nephrotic syndrome. And from the previous lectures, we know that most of the serum protein is circulating inside the circulation, and this includes the following. It includes the albumin, proteins like the globulins, and include alpha 1 and alpha 2 and gamma globulins, and also it includes the immunoglobulins, it includes the transferrin, and other protein like the antithrombin 3, and this need the albumin because it's make a complex to it, and include the protein C. Also it includes the lipoproteins and includes the carrier for vitamin D binding globulins and proteins. All these are here in the circulation, and because of the negative charge, as we say before, and because of here when it comes, it contains the negative charge, and because of the presence here of the fenestra and basement membrane and the podocytes, which forming the glomerular filtration barrier, so most of these proteins are going to circulate and go to the venous circulation, and it is not going to be excreted and filtered. Because of the derangement and the disease, all these proteins are going to be filtered here abnormally into the urine, passing in the proximal convoluted tubule and passing into the thick descending segment, then thin descending segment, and via the loop of Hilli, and it will go to the ascending segment, thin and thick ascending segment, then it's going to the distal convoluted tubule and collecting ducts, and then it will be going to be excreted in urine, and we get the problem of proteinuria. So here, because of the proteinuria mainly, we get hypoalbuminemia, but there are other factors, because not only the protein in the urine is related to the glomerular filtration. Sometimes we have proteinuria that are related to the tubular secretion of the protein. The tubule is get abnormality and secrete via the vasa recta, which are represented here around the renal tubule, which are the capillary network, and these are tubular proteinuria. And sometimes we have normal tubular, but because of hyperproteinemia, in which case we get this complication in certain diseases named as paraproteinemia. So back to nephrotic, because of proteinuria mainly we get hypoalbuminemia. Other factors is the decreased compensation of the protein and synthesis of a protein by the liver, and because the amount of the synthesized protein by a healthy liver is not sufficient to compensate for the amount of protein which is lost in the urine. The second, there is a shift of a protein between intravascular compartment and interstitial space, and again this can be attributed to hypoalbuminemia, and also because of the anorexic patient who got a chronic illness, and because of protein limitation as one of the measures of treatment, this also leads. So all these four mechanisms can result in hypoalbuminemia. This hypoalbuminemia can present as when they ask the patient about his urine, is any froth in your urine? Say yes. And this is the color and this is the shape of the urine during collection. When use the dipstick for measurement of the urine, it is tend to be changing the color in 1 plus, 2 plus, 3 plus. So because of that, we can use in investigations. One of the important thing is the checking in the urinalysis, general urine exam, what we call it, or in the urinalysis, we found in the dipstick, check the protein and albumin as 1 plus or 2 plus or 3 plus or more, and this is usually non-specific, can affect it. The more accurate is the measurement of the early morning urine protein to creatinine ratio or urine albumin to creatinine ratio, and this is going to be increased. Or the most accurate is the collection of a 24 hours urine for protein, and it depends if it is more than or equal to 3.5 grams. If it is more than 3.5 or equal, then it is nephrotic per day per 1.73 meters square. If it is less, then we call it nephrotic syndrome. So the other feature which we notice in patient who got the proteinuria and hypoalbuminemia is the picture of the white colored nail. It could be patchy like this, it could be diffuse all over the nails as seen here in the fingernails or in the toes nails, and this is what we call it leukonychia. So these are the signs of proteinuria, and this how to investigate. So if there is a problem, and this problem is there is a loss of a protein in the urine, to treat this and to make the kidney happy, so to make the kidney happy, and we have to first limit the protein intake orally to not more than 1 gram per kg per day, and to add the amount of the protein lost in 24 hours that we calculate. If we have a woman with a body weight of 50 kg, so she will need 50 grams of protein, and if the amount of 24-hour urine protein is 5.5, so she will need 55.5 grams per day of protein. So this is one thing which are related in the treatment for proteinuria. The second thing is for treatment of proteinuria, sometime we need to give the patient a salt-free albumin so that to control the state of hypoalbuminemia when it is severe, and this is usually an emergency situation. So we can't give a IV salt-free albumin, and it is usually recombinant albumin. We have to encourage a rest for the patient so that the amount of the leak, it will be get better, and to rest the disease, the kidney, and that can help. The other thing which is important here is the development. Because of this hypoalbuminemia, we are facing a problem because of this low albumin that will lead to the imbalance inside the vascular space between it and interstitial space, and the oncotic pressure, which is important to keep the fluid inside, is going to be lost and this or decrease. and this will lead to shifting the fluid from intravascular compartment to the extravascular compartment, mainly the interstitial space, and in addition, it will also goes to the third spaces. So by this, we are going to get volume depletion and orthostatic hypotension, and this will lead to ischemia and decrease of perfusion of organ, like the renin-angiotensin system, which is going to secrete the renin because of hypoperfusion, and the renin will stimulate angiotensinogen to form angiotensin 1, and this by angiotensin converting enzyme in the lung comes to be converted to angiotensin 2, and this will stimulate the secretion of aldosterone. And we all know that aldosterone is acting here in the distal convoluted tubule. This is the effect of aldosterone here, and also acting in the collecting duct. And this aldosterone is going to stimulate retention of sodium and excretion of potassium, and this will lead to, with water, that sodium will take water with it, so this will cause both sodium and water retention. And we say that the hypotension, which is developed also, will acting here. So this is the site of action in the distal convoluted tubule, not the proximal. And also it will acting here the aldosterone, the same thing in the collecting duct. And in addition to that, this problem of hypotension will lead to stimulate the secretion of arginine vasopressin, which is the antidiuretic hormone. This antidiuretic hormone acting here on the intercalated cells and parietal or mainly intercalated, it will act the antidiuretic hormone, also called vasopressin. And this is stimulate the retention of water. So we have aldosterone that causes water retention and sodium and excretion of potassium. So at the same time, there is a hormone which is the atrial natriuretic peptide, and this is secreted by the atria under the effect of hypotension, and this atrial natriuretic peptide is going to be decreased because the hypovolemia will be sensed in the heart, because the atrial natriuretic peptide, because the volume retention is going to be decreased, so the atrium will be collapsed, and this will cause inhibition for the secretion of atrial natriuretic peptide. And from its name, it's natriuretic. It's causing urination of sodium. So no or decreased amount, this means that decreased excretion of sodium, and this decrease in the excretion of sodium because of decreased atrial natriuretic peptide. Atrial natriuretic peptide will decrease sodium excretion. We have here retention, decreased excretion, so net result is sodium and water retention. And this should cause expansion of the circulation of the intravascular compartment. Back to the diagram, we found that there will be no expansion. Why? Because most of the fluid which are going to be retained here is going to go to the vascular space, and because of low oncotic pressure of hypoalbuminemia, high hydrostatic, normal hydrostatic pressure is normal, and it is not met by the normal but by low, so the net result initially is shift all of this fluid which is retained to the third space, interstitial edema, and more retain and more in the third space, and the intravascular compartment is depleted, and extravascular compartment is replenished and expanded, but the expansion will with time reach to the limit. So by this explanation we get underfill theory and hypotension, while we have seen patients who got hypertension and nephrosis. What and why? The explanation that we have a time that we reach to equilibrium. That is to say, this is the intravascular compartment and this is the extra or interstitial space. Initially, the low albumin and low oncotic pressure and high hydrostatic pressure. It will shift the fluid to interstitial space. More and more the fluid is expanded in interstitial space and we get rising gradually of interstitial space hydrostatic pressure. So by the time we'll get intravascular space hydrostatic pressure coming in equilibrium with extravascular space hydrostatic pressure, and we reach to the state of equilibrium. So the more retained fluid is going to be stay here or divided here and here, because there must be an equilibrium in hydrostatic pressure. So with time we will get expansion of this and more expansion of this. So edema get to the tense level, but we will start to get normotension or even hypertension. We know that the effect is, when we look at the vessels, we know that these vessels containing tunica, intima, endothelial cells, containing muscular layer and adventitial layer, and this is the blood. And because oncotic pressure is decreased initially, so this is one force, but we have to have permeability of the vessels. So if the vessels permeability is changed, again this can increase resistance, decrease resistance. This can also affect, and we have so we say that impermeability and certain illnesses that cause nephritis can affect also the permeability. Age of the patient and atherosclerosis, also this affect permeability. So there are other factors behind why some patient in nephrosis and proteinuria having hypertension, other having hypotension. Characteristically, because of this shift of fluid to the interstitial space, so initially the patients will get periorbital early morning edema, and this happens, and he looks malaise, depressed because of the illness. With time, edema getting more in the dependent part of the limb and causing pitting legs edema, and we can use rule of one, and that's to say one finger, usually the thumb, for 1 minute and 1 inch from medial malleolus over the bony area. We press and we take off, we see pitting edema. With time, this can progress more, involving the genitalia to the degree that patients not to be able to wear their naps or their pants and their shoes, and even the clothes start to be smaller, need to take the clothes of his brother, big brother, and sisters, and because of the distended abdomen ascites, or because of pleural effusion, or this is the cubitus of view, and sometimes even we may get large pericardium because of the pericardial effusion. All these explained in the same way. That's why you need to rest the patient, and we need to limit fluid intake, limit salt intake, and to give diuretics, and that diuretics should think of diuretics initially to work on the loop of Hilli, that's to say loop diuretics, and sometimes we need to use an antagonist to the aldosterone, which acting here distal convoluted and in the collecting duct, and that to say we need to use the spironolactone and potassium sparing diuretics, and sometimes we need to use thiazide that acting on the ascending thick limb of Hilli. And we need to use multiple diuretic whenever resistance. We need to think of the edema of the gut, the tube that make the intake and oral intake of a drug is poorly absorbed. We cannot use it intramuscularly because of muscle edema, so it's better to use diuretic if can intravenously. So this is how to control edema in addition to control the proteinuria. And when we say there is hypotension, we need to take caution for hypotension in the treatment. And when we say hypertension, the best is to use drugs that decrease blood pressure, decrease proteinuria, and the best is the ACE inhibitors unless there is hyperkalemia or progressive renal impairment, or use ARBs, angiotensin receptor blockers, unless again there's sensitivity or any other contraindications. One of important thing that say we hear that we have a transferrin is going to be lost. That's why those patients may get anemic, and anemia could be of chronic disease, if associated especially with kidney disease, kidney failure, or of the iron deficiency. In that case, we have to correct anemia and investigate it by doing CBC, transferrin saturation, serum iron, serum ferritin. All these specific investigation are needed to be checked. If we think that there's kidney failure, we again check renal function test, urea and creatinine, and if it is failed, we need to limit diet and give treatment to support the kidney. And sometimes because of the, as mentioned before, loss of antithrombin 3, hypercoagulability, and factor 3 and factor 7, and they are going to be increased, and this causes hypercoagulation. And as you know, that this hypercoagulability may present as a DVT in lower limbs or upper limbs. It depends if the patient in the lower limb is immobilized, if the vessels wall having abnormalities, if he had varicosities or something like that, if there is any pressure over that veins. In addition to this hypercoagulability of nephrotic, make them to certain illness, as an adult membranous nephropathy may be complicated with renal vein thrombosis, and some patients may be presented with the sagittal sinus thrombosis or other venous sinus thrombosis of the brain. So thrombosis can happen everywhere in nephrotic in cases of hypercoagulability, and this differs from patient to patient, and need in that case to put in mind that antithrombin is lost, so it's best not to use heparin, and we can use prothrombin inhibitors like warfarin or vitamin K antagonist, and we can use also factor 10 inhibitors, and this is sometimes need to be added with other combined therapy. And what is also important here, because as I mentioned, there is loss of immunoglobulin. When immunoglobulin is lost in the urine, so this means that the immunity of the patients is going to be get lost, and the patient is exposed to the infection, and infection may be more in the skin, especially when there is severe edema that lost the integrity of the skin because of it. In addition to low immune system, make the patient liable for cutaneous infection, and any other site of infection can happen. This patient need to be corrected and treated and given specific antibiotics and other infection control measures. After all these, we need to give a specific therapy, because again we say lipoprotein is going to be also lost in the urine, And when lipoprotein is lost, and we explained before that the liver tend to compensate and to synthesize more cholesterol and more triglyceride and very low density lipoprotein, and this can cause dyslipidemia and can clinically observed by presence of the tendon xanthoma, or which is appear here in the eyes, and this is tantilasma, or maybe it's seen here when we open the eye we can see a yellow or whitish ring around the cornea, and this is so called the iris lipidus. And this can develop here. There is xanthoma over the extensor tendon or Achilles tendon, in the elbow, in the Achilles, in the knuckle of the hands. All these can develop also xanthoma, and this is feature of dyslipidemia. This is may worsen, may present it sometime because of high triglyceride with pancreatitis and inflammation, or may present it with a coronary artery disease because of this atherosclerosis. Of course, this will lead to be statin to be used, limit fatty diet, and when you use statin, it's also help in decrement, especially atorvastatin, the proteinuria by decreasing glomerular sclerosis. More and more proteinuria, and if the patient was not compliant and still eating more protein, so whatever protein he eats, he will last in the urine. And as far as there is more filtration of the glomeruli of the protein, so more filtration of this glomerular protein, this will lead to the glomerular sclerosis and will progress into CKD. So this is again important thing. What is the prognosis? It depends. We have always to think of the cause and treat the cause, and after all we have to treat specific treatment for nephrotic. It depends on the biopsy. After we take it, we can use steroid, and we can use steroid in a dose of 1 to 2 milligram of oral prednisolone per kilogram body weight per day for 4 to 6 weeks, and once we get response we start the gradual taper, and we take the precaution of side effect of steroids. Again, we can use immunosuppression, and according to the biopsy and to the indication. And after all, I have to thank you and for listening, and maybe long lecture, and for any question please don't hesitate to ask me, and thank you very much.